Just giving people a chance to log in, and we'll begin with the CCRS reports and the Medicare software. Again, good afternoon, everyone in Toronto. I'm coming to you from Costa Rica in the south along the Pacific Ocean. So I'm hoping you're all able to hear me quite clearly and you're able to see the screen without any problems. If you could please note that you've been muted on your end just because of the number of individuals sites that we have logged in to this webinar. But there is the ability to leave messages or ask questions, and when the seminar is over, I'll look at those questions and address them and send out an email to everybody. Unfortunately, there's just too many of us at this time, and we've only got a single hour. Now, the other thing I noticed as I was preparing for today, and today's looking at the CCRS, or the Continuing Care Reporting System, and we simply wouldn't have enough time today to do all the different reports and do them well for the complex and continuing care reporting system. So what I would like to do is actually have a CCRS Part 1, which would be today, CCRS Part 2, and then CCRS Part 3. So it's going to take 3 different 1-hour sessions to go through all of the CCRS reports. And then we'll simply have the other sessions that have been planned for care planning and so forth just moved along so that we keep the same grouping, but we'll be able to cover CCRS in the kind of depth that it's going to need. So I hope that's not a problem for anyone, and you'll be able to readjust your schedule accordingly. So the assumption I have here is that everybody is a Medicare client using the Medicare reporting system. And we're going to go through and look at the different reports that Medicare has. Now, as an overview, you can see I'm on the home screen, which you probably are aware of, and I'm going to click on e-reports to get to the reporting system. Now, clicking on e-reports takes me to the list of all of the different reports that Medicare has. And you can see here on the left-hand side of the screen, we have reports related to the admission, discharge, and transfer, reports related to care plan, to the community health assessment tool, so that's reports that are unique to that tool. The CCRS tool comes under what's called complex and long-term care. So any report that's underneath this grouping, which we're covering today, all of these reports that you see all have to do with CCRS data. Okay, so you may have things like diagnoses reports that appear somewhere else in Medicare, but these reports pertain only to the CCRS assessment. So those are all independent. We then have an area called custom reports where you can build your own report, and we're going to cover that on another day, so I'm not going to go into huge detail. But you can see here's where you can build your own reports. And that means that any assessment, whether you built the assessment yourself using Medicare's assessment builder, or if it's a standard assessment within Medicare, you can create your own report from that data, and we'll look at that in a future date. We also have financial reports, so all of the sites that are working with Medicare's financial software, you can see there are reports to deal with census and bed management, billing, the trust system, transaction journals, listing of different journals, and some head office reports that are unique to those who have more than one site. Okay, so today we welcome Ottawa, for example, and Ottawa has 4 different sites, and Medicare has just recently begun to develop their reporting with them. Then we have progress notes and incidents. So anything to do with progress notes or incidents that occur, and you need to get the statistics of how many people had a fall, how many people went to hospital. And so this gives us reports on all of the measures that are outside the CCRS. Okay, so typically these reports are things outside the CCRS. We then have a very large assortment of reports related to medications, reports related to mental health assessments, operational reports for those who have the security, and the operational reports simply give you things related to bed management, looking at care plan library, what is in my care plan library, what's in my relationship rules, employee information, things of that nature. So all these operational reports. And then we have reports related to rehabilitation, reports that are unique to retirement homes. So some of the reports are the same as what you would find here, only these reports are related uniquely to a retirement home. Okay, so those are the broad scope of all the different areas where there are reports in Medicare, and altogether there's more than 521 different reports. And so you can see why it's going to require us a number of different weeks before we can go through all of the reports in any detail. Well, today as we advertise, we're going to look at the complex care reporting system. And in Medicare, whether you're under the admission data, the care planning, the CHA, they're always organized in exactly the same way. These are reports that have to do with an individual. So here, all of the reports that are under individual reports are also under group. However, this is where I just want to look at a specific person and have a report that's unique to them. And generally, there's a lot more detail on these reports called individual reports. However, you can see RUGs is here, and I can look up a RUG score for a person and see what items impacted that RUG score and things of that nature. But we also have under the group reports, and I'll close the individual, under group reports, we also have RUG reports. Only this time I can pick one or more people. So, and I can break the data down by nursing unit or break the data down by different programs or different quarters. So under the group reports, there is a lot more detail, and I'm looking at the entire unit and I'm looking at an entire home all at one time. So that's the only difference between individual and group reports. And today we're going to stick with the group reports. Now this is where I mentioned we're going to do this in 3 parts. So we're going to begin today looking at the quality assurance reports and the MDS administrative type reports. The next time we're going to look at RUGs, RAPs, and we're going to be looking at the QIs. And then on the 3rd day, we're going to do CAPS, outcome scores, comparative scores, auditing, custom scores, and submission data. So we're going to do that in 3 different parts, and we'll send you out that information so that you have that well organized. So let's begin today looking at, again, remember complex and long-term care. That means both the hospital-based clients from complex care and the nursing home clients from what we typically call long-term care. These CCRS reports pertain to both those sectors. Now we're under the area called group, and we're going to begin with quality assurance. So let's just take a look at these quality assurance. Now, why do we separate that out from the QIs, such as the new 35 QIs? Because these are based on MDS data, but they provide more information than what you would find in the quality indicators, without all of the other things such as risk adjustments and population adjustments and excluding people who are new admissions and all of that type of stuff. This is raw data, right? So it's none of that other kinds of adjustments. And what might I want to know under this data? Well, how many people have 9 or more medications? And I want to run a report for my facility. Now, what I've done today in order to facilitate our time is I've already pre-run the reports. So I'm just going to open up this first report and we're going to have a look at how it's laid out. Okay, so what you see here is assessments with 9 or more scheduled medications. The total number of assessments involved are 92. The total number of medications for the time period that we're looking at, and here I've picked all of the active residents, is 1,154 medications altogether. And you can see the average number of medications are 12.5 medications per person. Now remember, we're only looking at people who have 9 or more medications. And this is pretty telling because 92 people are on 9 or more medications, and my total population here is 121 people. So it's only approximately 29 people who are receiving less than 9 or more medications. And I've asked the report to be broken down by unit and then show me the number of medications each of those persons are receiving. And so here you can see I've got 26 individuals in total, with average number of medications is 11.7 on unit number 3. Let me just go down a bit. On unit number 4, I've got 22 people, 11.5 medications on average. And then our next unit is unit 8. We're going to look at that one. You can see 22 people. And notice that 14.3 medications on average. So the other units have less than the overall facility average, which you see right here. And that particular unit is well above the other units for the number of medications. So that might be interesting to see, why is that particular unit? Right? And so you would know what that population looks like. This may be a dementia unit. It may be a unit where people are more medically complex. So whatever it happens to be, you need to bring your own knowledge into the report. But that report could help you to do a quick audit on those individuals and the number of medications that they're receiving. Okay, and remember this comes from CCRS. All right, so that's important. We're going to look at progress notes and medication reports, which will give us details specific to those tools, but this is your data captured on the CCRS. So let's just close that report and go back to the Medicare software. And what we want to do is see how this 9 or more medication report was run. So when I select it, you can see it gets highlighted in red. I can pick any date range I wish. So if I want to look at last year, the year before, or whatever it happens to be, I can do that simply by picking a date range. And if I wanted to see the change over quarter, how the number of medications per resident has changed over quarter, then you can see down here, I could group the data by quarter. So simply by clicking on the drop down, I want to look at changes over time. And I'm going to turn these two parameters off. And this will let me look at the same data, but give me the numbers by quarter. Okay? Or if I wanted to look within a nursing unit by quarter, then I could make that first parameter nursing unit. And then within that nursing unit, I want to look by the different quarters. Now, if you want to get totals, which is very handy rather than have to count them all, you could simply click these to get the totals by quarter, by unit, and by quarter. And that will help you to see that if you're programmed to reduce medications, if you have a program related to polypharmacy, if you have a program related to uses of medications, then you can see by unit where is the program actually working. Okay? Now, if I only wanted to go back a quarter, you can see here by clicking in the date field, I can pick any one of the last 6 quarters to quickly have it set the parameter for me. Or I could look at a calendar and do it by the standard method of picking a different date range if I only wanted to look at a single month. Okay? Or if I wanted to look at all my current residents on their last assessment only, just check off this box. This thing no longer applies. And that will give me all my current residents and how many are on 9 or more medications, which again may be more interesting to look at what's my current situation rather than bringing in historical people that were already discharged. So all of these parameters that you see here and how you'd like to group your data and get totals, this model works for every one of the Medicare assessments. All of them work exactly the same. Okay? So they may have a few extra things that you can do, a few newer parameters. They may even have a few less parameters. But you have that ability to build your data report any way that you wish. Now, another really handy feature in the Medicare system is that every report can be extracted out of the PDF format, which is the default you can see up here. The default format for your report is a PDF file. But what if I'd like to put that report into a different piece of software? So I could click Web Viewer function, then run this report, the same report again, and rather than have that report come up in a PDF file, it's going to come up in a new window, which will allow me to send my data to another application. All right, so I don't bother looking at the report from here. It's better to look at it from your PDF if you just want to view it on the screen. But I'd like to have this in an Excel spreadsheet. So I go here and say, please give me an Excel spreadsheet. And I want every page, and I want to export that data. And then you can see that rather quickly, it's able to put that piece of data, that report, into an Excel spreadsheet. And then if you know how to work with Excel, it's a pretty standard method of doing that, okay? And so now I can run different things using the same data, but I can run it using all of the features that Excel has. So I think that gives you a great deal of power in using that reporting system. And remember, every report can be sent out to Excel if you choose the web viewer option here rather than the standard output, which is Adobe. All right, so most times you'll just run it in Adobe. Now, if we have that part down, you can see now that every other report I'm going to look at today has that same capability. So let's look at people with cognitive functioning difficulty, again, taken from the CCRS, okay? And we'll look at that report. When you run it, this is what the report looks like. And I'm going to just make that a little bit larger so it's clearer for you. And here you can see we've got a little extra data added. And again, it's by unit. And you can see this is going to show us any assessment where a person has a cognitive impairment. And we're looking at people where cognition impacts function. So we know that the CPS scale of 3 or higher are people who have a cognitive impairment that impacts their function. And by function, I mean ADL and other things of that nature. So here you can see that we've got a person that they're in the extensive services group at the very highest level for extensive services. You can see their ADL for bed eating, toileting, and transfers in 18. Their overall cognitive score is a 5. And their decision making, remember from the MDS, decision making or cognitive skills for decision making is an item that goes from 0 to 3, where the person can make his own decisions if he's 0, or he has severe impairment for making his own decisions. And so this person with a CPS of 5 obviously is going to have decision-making problems at the very severe level. Okay, now notice this has a star beside it. And what that astra means here, you can go to the bottom of the page, and usually when you see those astras, the definition is here. That is, the person has moderate impairment for decision making, or 3 means the person is severely impaired for decision making. And again, I get the data by nursing unit. I can get the average ADL score. I can get the average CPS score for those persons. And you can see, obviously, you have a high score for CPS when you've got a high ADL. But you can compare each and every one of your nursing units to see which ones have the higher CPS score, which ones have the higher disability with respect to ADLs and their RUG score. Okay, so that's looking at that particular report. And again, let's go back and look at the parameters. You can see here, once again, I could group data by nursing unit. I could group it by program. So if you want to designate your residents as having, let's say they're in the short stay resident, or they're in a post-operative group, or they're in the dementia group and you don't want them included in your study, you just take the data off for that grouping of people and run it for all the others. So you have a lot of power and a lot of options here when you're running that data. Okay. Now the next one we're going to look at is disease diagnoses, which is this item here. And again, everything is the same on the parameters, except notice there's one new parameter. And this lets me look at the diagnoses with all of the details spelled out, or only show me people with the number of diagnoses they have. So let me just flip over here again, and we're going to look at people without the details. Look at the report there. Notice it's just a listing of report of people by nursing unit. It's telling me how many diagnoses each person has. There's someone with 8 or more diagnoses, 3 diagnoses. Now that's probably not all that helpful, but it gives you a quick and simple report. You can also see that on average, there's 6 different diagnoses, a total of 668 different diagnoses across the 116 people that have a diagnosis. That's also pretty interesting because I know I have 121 residents. So that's telling me right off on this particular assessment, that I have 5 people who have not had a diagnosis specified. And I'll show you where we can find that out in a moment. So let's just flip over. Oh, sorry. Now, this time I ran the report saying I want to know the exact diagnoses each person has, along with the list. And so here, if I click on this report, notice now this person with 5 diagnoses, just like before, but now it's telling me that in section I1, item number G, this person has checked off deep vein thrombosis, hemiplegia, multiple sclerosis, paraplegia, and seizure disorders. So once again, a nice handy report for each of the different units that I can quickly go in and see exactly what's happening with each of these residents. Now, there are other reports that look at diagnoses in different formats and different details, but this is just a nice quick summary if you're doing a review for your residents on a particular unit. Okay, so let's just close these 2 reports down. And we're going to look at those reports here. Please remember that when I ran the report the first time, I did not check off show diagnosis details. When I ran the report the second time, I said, give me all the details. Okay? So let's move on to our next report. So once we've done diagnoses, and remember, we're going to look at infections. Now, where does infections come from? That's section I2 on the MDS assessment. So let's just click on infections. I want all my active residents. I'm going to this time not list them out with just showing the number of infections. I want the whole detail. Okay, so I'm going to just show you the one report with all the details. And here you can see it's this report. And now I'm showing Aldolfo. And he had 2 different infections. One was the antibiotic-resistant infection, and the other is the UTI. Okay, and you can see right down again, getting the details by nursing unit of exactly what's happening. So here we have people with infection. The total number is only 14, where an infection has been recorded. Now, why might that be helpful to see that up here? Well, if I have 121 people, I'm pretty surprised that only 14 of them have an infection been recorded in their record. But maybe you'll know better than I do, but I find that a bit unusual. Total number of infections, 19. That's because some people have more than one infection. The average number of infection is 1.3. Okay? So we know that there's at least 8 or 10 different infections listed in I2. We're only showing an average of 1.3 overall. And again, we can look at totals by unit, what's happening on the different units. So again, helpful for each unit to be able to do the review with their staff in any particular area. So let's flip back. Remember what I've done here. If I didn't want to see the exact details, I turn that off. If I want all of the details as well as the persons, then I click it on. Okay? Let's look at our next one after we've looked at infections, and these are things related to incontinence. Now, do you notice how this is really different than what you would get out of the MDS quality report? Okay, this really lets me see exactly what's happening to whom in what areas, not just something that says 3% of people had an infection. Okay, so let's look at incontinence. This is going to look at both bowel and bladder incontinence. And we're going to run that report from here. And then here you can see I've got 108 people for whom data is recorded. Now, where's that data recorded? That's from H3A and H3B, the incontinence section. And it's the first two items in this, on the assessment. So 108 people. You can see the average number bowel, and then the average number with bladder concerns. And what are we talking about average? Well, we know that bladder and bowel is measured on a scale from 0 to 4, where 4 means complete incontinence, either for bowel or the bladder. And you can see these people have very high average score. Now for bowel, it's a 2 out of 4, but for bladder, it's a 3 out of 4 on average. Well, which makes sense, okay? So here's Aldolfo again, my favorite guy. It's a quarterly assessment. It hasn't been signed off yet. Remember, I'm looking at all my current clients on their most recent assessment that's been started for them. But you can see he's scoring 4 on both of them, and you have a complete explanation. Now, Luigi here, who's a BB1, what does it mean to be a BB1? He's a behavioral, right? This is looking at the behavioral rug grouping. Aldolfo's in the extensive services rug grouping. So this makes sense. This also makes sense, right? He's not qualifying for any of the medically complex areas. He's in that behavioral group for funding or resource need. He's not continent for bowel, but he's usually continent for bladder, but he does have episodes once a week or less. And remember, that's measured over 14 days. So what we need to do is forget about statistics for a bit, not totally, but let's look at what does it mean clinically for us when we look at this data. And again, I could see the totals by nursing unit to find out if one nursing unit has more episodes of incontinence and what type of incontinence they have. So again, I think a very good report if you're doing a review in that area. Now, special procedures. We know where this comes from. This is the group that comes from section P1A. All of those things that could happen while the person's in the hospital, right? Or obviously it could happen when they're in your facility as well. So these are the list of procedures. Let's just flip back. There were no special parameters on the incontinence. It's the usual parameters that we could set. And now let's look at special procedures here. Now under special procedures, this title is improper. It should have said show details of special procedures, not show infections. The developer obviously just copied the title over, and that's being corrected. So I want to show not just the list of people on special procedures, but I want to know exactly what special procedures each person has. Again, I'm using all of my active residents on their last assessment, okay? So let's just take a quick look at that report. Sorry, wrong report. That's the one with just the straight list of people and how many procedures. Let me get the one with the list with the details. There we go. So if we look at this on unit number 3, you can see this person has one procedure, and that procedure is monitoring an acute medical condition. This person has 6 procedures. This is Aldolfo again. Remember, Aldolfo had an SE3 rug grouper? That is the extensive services, the highest funded level in the system. He's got chemo, IV meds, monitoring an acute medical condition. He's on radiation. He's also on vent respirator. And under the program area, he's in a hospice program. Okay, so once again, a report by unit I think would be pretty handy for a review. Okay, and look at this here. 74 out of 121 people have at least one procedure or treatment. So that's fairly telling as well. And if you ran this report by quarter, it would be interesting to see if the number of procedures have been increasing or decreasing over time. And you can tell that you've got a fairly complex home here. All right, so let's go back. Recall here that I set this parameter to show me all the details. If I didn't want the exact treatments and just the number, I could turn that off. Okay, let's look at assessments with ulcers this time. Now there's a few more parameters here. Notice I can pick all nursing units or look at one nursing unit, which I can do for every report. I can pick all programs, or I can pick just one of the programs, which also I've shown in all the other reports. But here, the new parameter, what if I only want to look at the stage 1s? I only want to look at the stage 2s, 3s, or 4s, or I want to look at all stages of ulcer. Okay? And once again, I can group the data by unit, quarter, whatever it is I want to group it by, and get totals by unit. So this is a new parameter unique to this report. Now let's take a look at what that report looks like. So here, oh, sorry. No, Cortina, I don't need you. You can see here, I've got 55 of my 121 people have an ulcer at some level. The average for stage 1s is 1.7. The average for stage 2 is less than 1. So stage 2 is pretty rare. The average for stage 3 is even more rare, and the average for stage 4s is even more rare per person, which all makes sense. Okay, and here you can see where the data comes from. It's item M1A, which is stage 1 ulcers, how many? B, it's your stage 2 ulcers, how many? Stage 3 ulcers, how many? Stage 4 ulcers, how many? And you can see here they have 2 1s, and pretty much all the way down. Why do you think it's so unique that there's all 2 of those stage 1s? Because if you don't have at least 2 ulcers, there's no funding. So you have to have at least 2 sites, and just coincidentally, lots of these people have stage 1s with 2 sites. You can see there is one stage 2 here. That would not be funded because you got to have 2 sites, even though that's a stage 2. Okay, and then once again, you could see back here, oh, sorry, I get the total number of stage 1s on that floor, right? Total number of stage 2, there are no 3s or 4s for that particular nursing unit. Again, I think a very handy tool, quite different from the QI that only looks at stage 2 to 4s. And it also only looks at people who've been in the building at least 3 months. So this is really what I want to do in order to operate my facility, not just know some statistic. All right, so let's go back, back to our reports. Notice this was the new parameter, and we're going to carry on from the ulcers and look at falls and fractures. We know that falls and fractures both come out of the same area. We have all the standard parameters here. There's no new parameter, the date, the unit program, and then the grouping. That's sort of the standard that every report has. And we can just run that report. And let's just see what that one looks like. Now here you can see falls or fractures. There's at least 51 out of my 121 people who have a fall and or fracture. And then you can see here it breaks it down in detail for you. So this is fell in the last 30, fell in 31 to 180, a hip fracture, other fractures. And both of those are in that last 180 day. This is in the last 30 days for the hip fracture. Okay, and you can see here it's giving me that. But if I want the totals, which are what I would like to look at, you can see here I get the total numbers right here. I don't have to go through and count them all out, which in this case would be a little confusing. So the 30-day fall, I've got 8, 13, okay, out of a total 16 people. Now let's just go down. You can see the next unit is 5, 10, and then the total rate across is 23, 44, 1, and 2. All right. So that gives me a nice simple way to review that by unit and see if one unit is experiencing more falls and fractures than other units are. Okay, which I think is very handy. So we're going to flip back to here. And now let's move on past the falls and fractures to people needing feeding assistance. So guess where that comes from, feeding assistance? That's got to come from G1, right? And so we're going to look at everybody who has a sum score at least greater than 0 for feeding assistance. And we're going to flip over to the report, run that report, and here we go. So now this is what we would expect to see. Out of 121 individuals, 113 need feeding assistance, which is pretty significant. Okay, we're looking at the, here you can see the self-performance score for Aldafo. If you remember Aldafo, he limited assistance for eating, and a support is a one-person physical. And then you can just go through and see each and every score. And again, we're going to get the average at the bottom, okay? All right, so I hope this is clear, and you can see there's a lot of flexibility within the reporting system. Let's look at feeding tubes. We don't expect to find very many. The parameters here are just the standard parameters, nothing new. You always have to scroll down though, just in case there's a parameter hiding below your screen. And now what did Paul do? Okay, one sec. Obviously closed that window by mistake. Come on. And feeding tube. Now you're not going to be surprised if there's very few people, and we can see there's only 3. Also notice though, look at the rug grouper here, and that's Aldafo, right? With the extensive service, and this one's a special care group. So it seems kind of consistent that someone in both those medically complex groups may have a feeding tube. But again, it lets you say exactly on what unit and gives you the other statistics that you need. We're then going to go to the very next report. And keep in mind always, these reports are based on the MDS. Okay, here we're looking at assessments with weight gain. It's all the standard parameter. There's no fancy new parameter involved here at all. And we're going to just look at the weight gain report. And it just simply tells me this person has a weight gain following the parameters that's in the CCRS. And you can see what his current weight is as well as the ARD date. Okay. And that's, I mean, just a simple number. And the total number of people are 13 in the facility that have had a weight gain. Now, the weight loss is identical, so we're not going to need to go over there. And obviously we're getting a lot more people, 19 people that are currently in my building that have had a weight loss recorded on the CCRS. And again, I can see those numbers by nursing unit. And it looks like nursing unit number 8 has experienced the largest number of individuals with a weight loss. And again, that's significant. I mean, if there's nothing unique about unit number 8, then you would not expect it to have more than 3 or 4 as the other units are showing, but here we're showing 9, more than nearly triple some units and more than double in other units. Okay, so we're just going to close those. And now we're going to look at restraints. So I'm just going to see if there are any unique parameters with restraints. And yes, notice here it's got all the standard parameters. Again, it's going to show details, tell me what kind of restraints are being used, or I could just get an ordinary list of people and tell me how many restraints. I can also limit it by, if I only want to look at full bed rails, half bed rails, trunk, limb, or chair, okay? Or maybe I just want the ones on the QI, which would be trunk, limb, and chair, and just run the report for those people. So whatever way you want to be able to look at that, I would probably be taking both of those. Okay, and then obviously I'd want to group that by the nursing unit and get totals by nursing unit as well. Okay, and so let's have a look at that report. And here we go. Just like the diagnoses report and the infection report that we saw, you can see the first person here has a trunk restraint. And then you can see here, this person has a trunk restraint. Notice their daily use. So recall that that item looks at like no restraint, less than daily, or daily. Okay. And this individual has other types of side rails, example half rails. So the only ones that would show up on the QI is for Nikolai and then Landino. All right, because you know this one isn't part of the quality indicator report. So that lets us look at the reports that are under that one area in Medicare, under the group reports called quality assurance. Okay, and then you have all of these other reports that deal with the quality assurance items. So we just have 12 minutes left, and I want to quickly go through the next set of reports. And then again, remember, we're going to carry on for 2 more sessions on CCRS. So we're going to be getting into all that other stuff, such as the rugs, the wraps, you know, the quality indicators, all these other types of reports. Okay, but let's just look at these that I think the RAI really should be attending to. Now, this next group is really more uniquely defined for the RAI to help them manage what's happening with their assessments. So let's just click on MDS. Notice that we have a schedule for what assessments are due and what assessments are overdue. We have another report that looks at not only the assessment when it's due, but what is when is the sign-off date due, when is the wrap should be signed off, and when should the care plan be signed off. So this one gives you a lot more detail. And then this one organizes your schedule for each of your nursing units by which assessments have to be done in which week. So if you want to go in and run a report and say, show me all the ones due this week, that report will give you them by week, okay? And it'll tell you whether it's on Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, or Sunday. So I think that's a pretty cool way of looking at the data, especially if for whatever reason you've scheduled assessments to happen on Saturdays and Sundays, and there's nobody there to complete you know, those assessments, or look at them for those days. So whatever way you feel, but all three of these cover the same area of interest. So let's just look at the parameters. It's all of the same parameters. I'm going to click here. Remember, we're now under administrative MDS, okay? So we click on that report. There you can see it. This one gives you a couple of options. If you don't want ADT records like the admission and discharge shown, okay, are we back? Is everyone back with us again?
Yep, I can hear you now.
Okay, thank you very much. I just lost power completely here. One of the disadvantages of Costa Rica when you're in the monsoon season. Okay, we're back here with the screen. Let's just take a look at the MDS next schedule date. One of the new parameters is this one. I only want to look at assessments where there's X number of days left. I sort by, I'm sorry, how many days are left before it's due. I want to sort by the last assessment date, by the person's name or by the person's chart. So you have all of those options. You can exclude ADT data, which I never do, so I'm not sure who wanted that. I can exclude deleted records. Well, yes, of course. I don't want to see deleted records because they're not going to be scheduled and sent. And that one should be the default, and we'll look at correcting that as well. Okay, so that's for this report called MDS Next Scheduled. The next report is this one that looks at different events. Okay, and you can see it's identical to the last one for the parameters. Okay, and then this one called the monthly schedule, again, virtually identical to the last two reports that we looked at as far as the parameters go. But let's take a quick look at what the data is itself. And we'll go to that section on the administrative reports. And let's just look at the next scheduled date. Okay, and I'm going to blow this up so everyone can see it. And you can see it tells me the nursing unit. It tells me how many days they're either late or until the next assessment should be completed. And you can see here, obviously, this is fake data or old data that I'm using here. And you can just see that it tells me in a sorted order by nursing unit how many days before the next assessment is due. Okay. Now let's get rid of that report because the next one just expands on that report. And again, I'm going to blow this up. This one tells me for this one individual, and let's look at Aldolfo. This individual, what's his chart number? When was he admitted? The last assessment he had was a quarterly. The next assessment will have to be a full annual. So it's just telling me because this was the third quarter assessment. This is the annual. The next scheduled date is this date. The 7-day look back from that ARD is this date, so that's when you should start your observations. The 14-day look back is this date. The R2B date when you should sign off is this date. The RAP should be signed off on that date, and your care plan at VB4 should be signed off on that date. Now, most people are signing these both off at the same time, the care plan decision and the RAP assessment completed. Okay, so that report is like the last report, only we're bringing in all of the events that should happen right up to VB4 on your assessment. Now, the next report just adds in this concept of organizing your assessments, but this time we're going to organize them by the, we're going to organize them by the days of the week. So here you can see it shows me the week and the date range for that week from February the 25th to March the 3rd, and it's a Friday is when that assessment. So I've got 2 to do on in that week. I've got 2 to do on Friday. I've got 2 on Sunday, and then in the next part you can see how it's organizing it. Just so that you're able to organize your units by what day they should be done on. And you'll notice that some of these are falling on Sunday, Saturday, Saturday. Okay, so again, that might help you. Also, you can see here it's giving me when the RAP should be done, the care plan, right? What's the deadline? Next quarter care plan target date. And notice it's saying how many days between assessments if you do it on the expected date. So you haven't changed your ARD to go out past the 92-day window that you should have. So that's just helping you to make sure you're not going to have late days. All right, notice here 93 days between if they use the ARD date that was set by the RAI coordinator. So that one's going to incur 1 late day penalty. Are we okay there? And now we're just coming, another 3 minutes left. The rest of these reports, I'm not going to go through all of the parameters because each and every time we look at the parameters for these things, whether you're doing the active resident list, what was the admission status for the people who came in? What was the discharge status for people in the last quarter or month? If you want to look at length of stay, given the AB1 date in CCRS, diagnoses. These look at the ICD-10 diagnoses that come from the MDS, not necessarily the ICD-10 diagnosis in your medical record or showing up in your care plan. Okay, so let's just quickly look at that one. Notice I can also list the residents with each diagnosis or just list the diagnosis out. I'm going to take the more complicated one. And you can see here, all of these people do not have a diagnosis, okay, which would be pretty incredible, correct? And then you can see these are people with ICD-10 codes. These are ICD-10 codes, okay? So those are all of the ICD-10 codes, and you can see it's Rosemary here. Then you can see each person here, right? And so you can tell in this facility, they're rarely using that section I3. They're mostly just using the checklist and not recording diagnosis under the I3 section, which I do understand is optional. Right at this time, I3 on the MDS is an optional section, so you're not getting any diagnosis or few diagnoses listed, and there's only a few cases where they are. Okay, so let's skip out of there. You can also receive a death listing report. Again, it would have exactly the same parameters. Okay, nothing unique about the parameters except for this one. I want to know what death events happened in the last X number of days. Okay, so if you wanted to get the death listing, if you put 0, it ignores it. Okay, and just gives you every death listing. And you can see here all deaths if you pick that parameter, or you just want deaths within a certain month or quarter or week, whatever it happens to be. All right, then we have what's called the facility profile. You should be accustomed to this report if you're the RAI, because this is the data that you send to CIHI every April the 1st. So you probably sent this report, or not the report, you probably sent this data to CIHI, giving them your facility name, your facility number, right? Who does the data submissions, who's the database manager, all of those types of things. So this is that data that you have to make sure is correct when you begin to do your submissions in the new year. Let's then flip back to the verified key report. Again, only the RAI would be interested, but this is the data that CIHI verifies when they reject or don't reject a record that comes from you. Okay, so you know how you have two types of rejections, or three actually, but one rejection is I just reject the file, and the other rejection is I reject it if the data is wrong. But you at least got to have this verified key where you've got the person's health card number, gender, date of birth, and so forth. And that's what CIHI initially looks at before they look at the data. Okay? So you want to make sure all the data is there. And I find this report very interesting. This report tells me what work you did that quarter. So how many admission backgrounds did you do? How many admission full assessments did you do? How many annuals, significant changes, significant corrections, quarterlies, no discharge, no return, discharge, return, discharge prior to completing the initial, how many reentries, corrections, how many med records did you send? Okay, and you can see for that quarter, we sent a total of 164 records altogether. All right, so I think from an RAI perspective, that gives you a sense of what your workload's been. Okay, everyone, I know I ran a bit late there, 2 minutes. We're going to finish up for today. We're going to begin again the other reports. As I suggested, the RUGs, the QIs, all of those reports past the MDS administrative and looking at RUGs, RAPs, QIs, outcome measures, custom reports, all of those things that we can have. We'll get all of those done in the next 2 sessions. Thank you for bearing with me in our little service interruption there, and hopefully we'll see you all next week. Thank you. Bye-bye.